Sainsbury accept to come and he had organized the vaccine strategy in UK for years, and I've been very upset by the way he had been able to drive a very good politic on vaccination compared to what we've done in this country, where it is a mess. So it is really interesting to see how we have been able to manage it, how we think about vaccination, and how he sees the future of vaccination. Because it's a major goal and it's always changing, and then you need to be clever and courageous to make politics of vaccination. You cannot just reproduce what has been there before. You need to be active, convincing, clever, and very strong to do this. So I'm happy with you.
Well, thank you for the introduction and thank you for the opportunity to be here. It's a great pleasure to be here. I'm sorry that my lecture will be given in English. If I was to do it in French, it would take a long time, and my grammar is not good enough. So I will have to resort to speaking in English. You would think that this question was very simple. Of course we value vaccines. Why would we not value vaccines? They are the most cost-effective intervention after clean water. You will see that written many times, and it's become an item of faith that when people talk about vaccines, they just say they are the most valuable intervention. There's no problem. But it's not that simple, and I want to try to show you through the course of this presentation why actually we have to think very carefully now and in the future about how we value vaccines. And I'll start by just showing you why it's almost obvious that we value vaccines. And this is just data from the United States, and we can argue about whether the data is good or bad, which depends on the quality of surveillance. But nevertheless, the indications are pretty clear. That if you take a list of vaccine-preventable diseases and you look at the numbers of deaths in the era before vaccines for each of these, and then you look at recent data on the numbers of deaths in recent years, and you find, sorry, this is morbidity, you find this huge reduction in morbidity against pretty much all of them. The only one that stands out, really, is pertussis, where we're not doing anything like as well at preventing pertussis as we have been in many of the other vaccine-preventable diseases. That's another story, and I don't want to divert into that. But if you look at the reduction in morbidity in pretty much all of these, we're looking at close to 100% reduction in morbidity after the introduction of vaccines. So just simply looking at what is achieved, you would say, of course we should value vaccines very highly because of what they've been able to do. And you can take a few more, and again, these vary a little bit so that the decrease in morbidity is not as good, but nevertheless, there are considerable impacts with the introduction of specific vaccines against the target diseases. So that could be the end of the lecture, and we could all go and sit in the sun. We value vaccines very highly because of their impact. But let's look at some other ways where we might value vaccines. And again, here a very simplistic analysis. For every dollar that the US spends on childhood vaccines, $10 is saved in healthcare costs. So we can argue about how this was constructed and whether it's valid and whether vaccines are truly cost-saving. It's very rare that they are indeed cost-saving, but nevertheless, you spend money on vaccines, you save money on health expenditure. So again, that looks easy. Your childhood immunization program, you spend money, you don't get disease, that's a good use of money. End of lecture, all go and sit in the sun. life gets a bit more complicated. Here's a way of making comparisons of diseases and other things that happen. And so if you look down the left-hand side of the table here, you see the numbers of cases of different diseases at different times. So in 1923, 1,500 people got tetanus. 1941, nearly 1 million people got measles. 1968, 152,000 got mumps. 1969, 57,000 got rubella, and so on. And then you look at what happened to those diseases more recently. 37 people got tetanus. At the same time, 37 people were struck by, died from lightning. So you would say that tetanus has become extraordinarily rare. You're as likely to get tetanus as you are to be killed by lightning in the United States. And in 2013, there were 55 cases of measles, and 169 people climbed Everest in a single day. And you can see again that 600 people died falling out of bed, and 229 people got mumps. So diseases have become as rare as things that we think are rare. So they must be valuable. So we should again go and sit in the sun. Things started to change in the way that we thought about our vaccine preventable diseases. And I'll take you through a few examples. So in 1988, in the United Kingdom, a decision is going to be made to change from giving measles vaccine to all children when they're just over a year, to giving rubella vaccine to boys and girls at the same age, whereas at that time we were just vaccinating teenage schoolgirls, and we have no vaccine program for mumps. So we're going to switch from that to giving measles, mumps, rubella combined vaccine at a year of age. So we go to the Treasury to say that we want some money. So they say, okay, prove you need it. So the proof that you need to generate is like this. You need to show that going from single measles to combined MMR is going to be advantageous against measles. So how can you do that other than being able to show that the coverage that you had before for single measles is going to be increased by the use of the combined vaccine so that you prevent more cases of measles? So the first thing is you've got to show that there's a benefit against measles. Then you have to show the marginal benefit from giving rubella to boys and girls compared with just giving rubella vaccine to the teenage girls. So you've got to show that there is a marginal benefit from changing your strategy. And then you've got to show that vaccinating against mumps is cost effective. So if you want to use MMR vaccine, you have to show that each of the changes, measles, mumps, and rubella, each of them is cost effective. Well, that wasn't in itself too difficult to do. So we did the analysis and we convinced them that that was going to be cost effective. So then a couple of years later, we want to come back and say to them, actually what we now want to do is give 2 doses of measles, mumps, and rubella vaccine. A dose at age 1 and a dose at age roughly 4 years. And the reason we want to do that is that it's clear that if you fail to vaccinate everybody against measles, and because measles vaccine is roughly 90% effective, you're going to accumulate susceptibles, so you need to give a second dose to get rid of the susceptibles. And you can take the same argument further on. So the Treasury then says, okay, you want to do that. Show that this is a good use of resources. Show that giving the second dose is cost effective. You want to use the money? Show that it's worthwhile. And life then starts to get really difficult.
because they want us to show that the second dose of measles is it cost effective, a second dose of rubella is cost effective, and that is very difficult to show because a single dose of rubella vaccine gets much higher effectiveness than measles does. So with a single dose of rubella vaccine, you get 95% seroconversion. So arguing that rubella is the same as measles is not easy to do. Mumps is relatively easy because the efficacy of a single dose of mumps vaccine is probably only around 85%. So if you give one dose, you accumulate susceptibles, and then you'll have outbreaks of mumps. So we came back to the Treasury and said, yes, we can show cost effectiveness of 2 doses of measles. Yes, we can show cost effectiveness of 2 doses of mumps, but we can't show cost effectiveness of 2 doses of rubella. So their response is, okay, then you just give mumps rubella vaccine. Well, that didn't exist. So we had to say to them, it doesn't exist. And they then said, okay, we will accept that only 2/3 of your new program will be cost effective because there is no alternative. But the arguments had to be demonstrated. So life is starting to get more complicated because just showing that you're going to prevent disease is not adequate. You've got to show that you're going to prevent disease and it's going to be a good use of resources. So I'm now going to start to show you about how we use those sorts of principles. And this was a very simple model that was used. We took the number of cases, we took the efficacy, we said this is what we will, and the coverage, and we said you multiply the efficacy against the coverage, and the previous number of cases, the number that will reduce. That's it. Life was very simple. Things got a bit more complicated when we then faced increasing numbers of cases of meningococcal disease. And here you can see meningococcal disease over the period of 1994 to 1999. And in the greeny-blue color, you can see group B meningococcal disease. And in the pink color, group C meningococcal disease. Now, at the time, we knew that there was no prospect of a vaccine against group B disease. Didn't exist, and the science wasn't there, wasn't going to exist against this condition. But we knew there were very high prospects of making a vaccine against group C disease. So you would think the arguments are fairly straightforward. Look at all the numbers of that's not what I wanted. Look at the number of deaths from group B disease, and they are all really focused here. So if you wanted to prevent that, you'd need a vaccine for young children. But if you look at group C disease, apart from the very youngest, group C is predominating, and then you've got this big adolescent peak of group C disease, the deaths here. So your vaccine program is not just going to have to deal with here, it's going to have to deal with here, and it's going to have to be cost effective for preventing these deaths and preventing these deaths. So there's no doubt about the burden of disease. So we produced a model that was pretty simple. And what we've done here is look at different ages and the numbers of doses needed and the financial consequences in terms of disability-adjusted life years. Disability-adjusted life year or a quality-adjusted life year is a way of valuing the numbers of years of life that would be lost from disease that would then be prevented against the ill health that comes as a consequence of the disease in terms of the acute phenomena and the sequelae. And so what you can see here is that if we were to vaccinate infants with 3 doses, we'd have some costs. If we used 1 dose for the 1 to 2s, 1 dose for the 5 to 9s, 10 to 14, and 15 to 19 age groups. So clearly, if we're, and this is per 1,000 people, if we're looking at the youngest children, we get the most life years saved because you protected them at a young time, so you're going to get the most life years over their lifespan. And the number of life years that you save will diminish with increasing age of vaccination. And here are the sequelae that will be saved. And you can then get a total for the disability life years, and then you can cost, because you know the cost of your program, you can cost each disability adjusted life year. And so the most expensive strategy is this one here, where you give 3 doses of vaccine to the youngest children. It's the most expensive, obviously, because you've got the cost of 3 doses, and you've got the cost of administering 3 doses. You get the benefit that you get more life years saved, as you can see at the top. So that strategy is the most expensive, and the others are much cheaper. In comparison with other health interventions, this is extraordinarily cheap. You're going to see later in this presentation, but just to start off, the threshold used in the UK for cost effectiveness is 20 to 30,000 pounds, so 25 to 38,000 euro per life year saved. So any intervention that comes in below 20,000 pounds is a good use of money. An intervention that's going to cost you more than 30,000 is going to displace the use of money from something that would be better value. So if an intervention is costing more than 30,000, it's not going to get funded. If it's less than 20,000, it'll get funded. And this is a very rational way of allocating health resources. So here you can see that our vaccine program, whichever strategy we use, is extraordinarily good value for money. So we go to the Treasury and we say, this is what we've got, what do we do? And you've seen on that early graph the number of deaths that there were in the children who were less than 1 and between 1 and 2. And so they are not going to be prevented, we think, with a strategy that does not vaccinate the youngest. So if we took the most expensive program and say, don't do that, you're still going to get those deaths, which will be politically very difficult. So the Treasury is made up of people that are not just hard finance people, they are rational, sometimes. And on this occasion, they said, we accept that even the more expensive strategy is still incredibly cheap. So do the whole program. So we vaccinated all children up to the age of 19 years in school. In a huge program, we did vaccination of the children under 5 in primary care. We vaccinated all of the rest of the children in school, and we got very high coverage. So we get the return on the investment that we thought. But we again used a pretty simple model. The model that we used said, this is the number of cases of group C meningococcal disease that we've got at the moment, and this is what we will gain if we prevent those numbers of cases. So it's a static, non-transmission model. So we're not looking at the interplay between vaccinees and non-vaccinees, partly because the sophistication of computing wasn't available to us, and also because we did not know what would be the impact on transmission, which is a key part of any vaccine strategy. So we may well have been underestimating the benefit. Life got more interesting after the program had been introduced, because what we can see here is what is the effect of the program on the unvaccinated. Now, let me just take you through this. So what we've got here are the ages of the groups who are going to be vaccinated, as I've already shown you. So that's infants right the way up to 18 years of age. And what you can see here are the attack rates per 100,000 before the campaign. So the attack rate in the 15 to 17 was 5.28 per 100,000. In the 11 to 14s, 5.54. And going down to the youngest, 7.5. So that's the attack rate before the program. What you can see here is the attack rate after the program in unvaccinated. So you've got a reduction from 5.28 to 1.79 in the unvaccinated peers of the vaccinated children. So by vaccinating high proportion, we have achieved population immunity. We have stopped transmission. And we never value in our cost effectiveness what would be the benefit to the unvaccinated by vaccinating their peer group. So this is now saying what would be the benefit of stopping transmission, so that you don't just have a benefit to the vaccinated, but you have a benefit also to the unvaccinated. So instead of saying we multiply our effectiveness by coverage, that will underestimate the benefit if the unvaccinated are also going to benefit. And here you can see the percentage reduction. So our models need to become more sophisticated to start to value the impact on transmission. Here's an example that then was done after the data was known. We had to do our estimates before the program. To justify the money, we had to use estimates before we knew the answers. Here, they've developed models after they knew the answers. And this is the cost per life year saved. And here's our 20 to 30,000 pound band, where we say if it comes below this threshold, we'll spend money because it's a good use of money. And here is the situation that we had. We're looking at a high incidence of disease, which is what we had, and we're looking at various case fatality ratios. We've got high case fatality, medium case fatality, low case fatality, at a time of high incidence. And what you can see is the probability of it being cost effective, the proportion of simulations that are cost effective. And it doesn't matter which of these you take. It doesn't matter whether the case fatality is high, medium, or low. At a time of high incidence, it's always going to be a good use of money to prevent. So you have an extraordinarily high probability that it is going to be cost effective to prevent these cases. It gets more difficult if you've got low incidence. So if you were to ask a question at a time of low incidence, should we be preventing these cases? And here we've got the high case fatality, medium, low. At the high case fatality, low incidence, you've still got a very high probability that it's going to be cost effective, because you're still in the 20 to 30,000 band. But as the case fatality goes down, so the probability that it will be a good use of money is also going down. So low incidence, low case fatality, and the probability that it's going to be cost effective is only around 30%. And you won't get that money. So depending on the circumstance, it's a good use of money or it's not a good use of money. Group B meningococcal disease becomes even more difficult. And with Group B meningococcal disease, we have to first of all look at what happens over time. And this is looking all the way back to the beginning of the 20th century, where it was called cerebrospinal fever, then it was called meningococcal infection, then it was just meningococcal meningitis that was reported, then meningococcal meningitis and septicemia, and we're coming into an era around here where PCR is being used to confirm the diagnosis. And the problem with group B meningococcal disease is that it's entirely unpredictable. And we are now going into an era where, of its own accord, group B meningococcal disease is going away. But we now have a vaccine, which we didn't have before. So all through this period here, we have no vaccine against group B meningococcal disease. But now that we have got a vaccine, we've got a bit of a problem, and that is that the disease is going away on its own. So what do you do? And this line here, these two lines here, reflect the sort of averaging, taking a lower value and then a slightly higher value for anticipating the future and then bringing that into modeling backwards. So unless you're at a time of an upsurge of meningococcal disease, you've got to have a problem. And so a lot of modeling has been done in the UK looking at meningococcal disease. And as I've just said to you, this is group B meningococcal disease, and of its own accord, it's going away just at a time when a vaccine becomes available. But what you don't know is what will be the future, because you can't trust meningococci to behave themselves. And so just when you think you know what the meningococci are doing, you can then start to make some sort of model. And here what we've got is a series of choices. And remember, our 20 to 30,000 threshold is down here. And we're looking at a range of different interventions and a range of different vaccine costs. So you can now start to model what will be the impact of different costs of vaccine. So here's a vaccine that costs, I can get this back. So this dark line, if the vaccine costs £40, the vaccine efficacy is 75%. And if it costs £40 and the efficacy is 75%, there is no way, here is our bar, I can see it, I'm not sure if you can see the 20, can you see a greyish bar at 20 to 30,000 pounds? Just. Okay, well, there is a grey bar that I can see here at 20 to 30,000 pounds. And so that you should just be able to see there a grey bar. So that's our cost effectiveness threshold. And that dark blue line, £40 per dose, 75% efficacy, is never going to be cost effective. And even if you took this one, where the cost is £10 per dose, and the efficacy is 75%, even there, and you take the upper bound of the 20 to 30,000 pounds, even then, you've only got a 40% probability that this is cost effective. So you've got a vaccine, you've got a disease that everybody fears, that nobody wants their child to have, the sequelae are awful, but it's really tough to show that this is cost effective. So there's been a lot of debate about some of the issues. Now, here you can see, and I'm not going to go into all the detail of this, but these are the things that were taken into account in the model. The vaccine has to cost £3 a dose to be cost effective. These days, no vaccine costs £3 a dose. You can't buy a vaccine at £3 a dose, and certainly not for a new vaccine. And an adolescent strategy would actually, vaccinating adolescents would be the most cost effective rather than vaccinating infants, because then you will have an impact on transmission. But it will take years and years and years for that to work. So the modeling is here unhelpful. If we'd gone back to our early way of looking at things, nobody wants this disease, it kills children, it's got horrible sequelae, we've got a vaccine, we should use it. But when you start to get into this rational analysis where you model the strategies, you model the consequences, you find it very hard to justify the use of resources. Now, with a lot of manipulation of some of this modelling and of negotiating of prices, the UK has introduced a Group B vaccine programme vaccinating infants. I would not want to know some of what must have gone on behind closed doors to come to some sort of agreement about this. But it was not really supported by this evidence. The programme started last year, in June of last year, to just vaccinate children when they became 2 months of age. So it was a program introduced for new cohorts into the vaccine schedule with no catch-up. And then a few months ago, a mother posted pictures of her daughter on Facebook. And what she posted was this. And that's her daughter, and that's her daughter. And this was just before her daughter died. And the reason that she did this was that her daughter was over the age to be included in the program. And so she felt that all children under the age of 12 should be vaccinated. Because if they had been, this would not have happened. Her daughter would not have died. And this Facebook posting, I think it's a misuse of the term, but it went viral. And it stimulated a petition to Parliament. And in the UK, if a petition gets more than, I think it's 100,000 signatories, there is a requirement that it is debated in Parliament, that it will trigger a parliamentary debate. And this got 750,000 signatories, more than any other petition that has happened. We know from the data that I've shown you that under no circumstance would it be cost effective to vaccinate all children up to the age of 12 years. So this creates a political dilemma. The politicians can see that at least 750,000 people want the policy to change in a way that can never be cost effective. So the politicians had their debate, and they said a number of things that were frankly wrong, because why would they know what the correct information was? They said a lot of emotional things, but some people did steer towards the reality. And so here, one of the members of Parliament who is a doctor says, this is a very serious condition, but if we're to run vaccination policy purely on the size of a petition, we would run ourselves into very difficult territory. She added there was a case to review the formula that's used to weigh up cost effectiveness, which I've already shown you, but I think that is what should happen now. Well, there is a review ongoing, it already was ongoing, and it just shows that she didn't know all the background, which argues, to my view, that these are not political decisions, because they don't know terribly much about the circumstance. But nevertheless, a politician here is speaking to the reality. And it then gets reported in the Lancet, and the conclusions are pretty sensible. Paying for vaccines requires hard decisions, especially when subject to the full glare of public scrutiny. There is no easy solution. Each case will be debated, settled, and judged on its own merits. Meningitis B vaccination seems this particular debate is now over. So the politicians will have their debate, and they may even come to a particular view which will be swayed by emotion. But the reality is that our decisions, which previously were made on very emotive grounds, are now being driven by resource availability and value for money. But that's a bit too easy. Let's look at how we use some of this to decide our expenditure. We went to modelers about influenza vaccination and said, is our current influenza vaccine program cost effective? And should we extend it to vaccinate more groups? And here are all the choices that we said to them to model. Should we vaccinate young children? Should we vaccinate the healthy, older group from 50 to 64? And here are all the things that we said to model, and assume that you only have 30% uptake in each group. And tell us if it's good use of money. And they said that some years you give flu vaccine and it's a complete waste of money. Because some years there's no influenza. Influenza is unpredictable. Some years you have none, some years you have a lot. So a year when there is no influenza, you vaccinate because you have to vaccinate in advance. You have no idea whether there will be influenza or not. Some years you waste all your money. But that doesn't happen very often. Most years, flu vaccination is cost effective. And if you take an averaging over a decade, it is good use of money to vaccinate against flu. And you can see here the cost per quality adjusted life year from the current program over about 10 years was £5,500. Compared with our threshold, 20 to 30, this is extraordinarily good value for money. So the seasonal influenza program is really good value for money. You'll read a lot of controversy about whether we should vaccinate against flu, whether it works, whether there's a mismatch against the strains. Forget it. Flu vaccination is really cost effective. But it's, and here are just the backgrounds to the modeling. It's not worth going into all the detail. But what it comes up with at the bottom is that targeting transmitters would be really good use of money. And transmitters for flu are children. So we obsess about vaccinating the 65 and over age group. We obsess about vaccinating people with risk factors for flu. The most valuable would be to stop transmission. Remember the meningococcal group C model I showed you with the benefit from transmission blocking. Here, if you block the transmission of flu by vaccinating children, that would be the best thing of all to do. And here again is one of these similar things. Here's the probability of it being cost effective. Here's our threshold, 20 to 30,000. And then here's what happens in a year when you've got high coverage, when you've got well-matched vaccine, and you are stunningly cost effective. You've got 100% probability that it's cost effective. But as you go down looking at pessimistic expectations of the vaccine with a mismatched strain, there will be times when it's not really cost effective. But over the majority of years, your vaccine program for flu is highly cost effective. So, on average, the current vaccination program is highly likely to be cost effective. Vaccinating children up to 16 years, likely to be cost effective. Vaccinating low-risk adults, not cost effective. These models are robust to uncertainty, and the benefits of vaccinating children would accrue to other people who are in high-risk groups. So you vaccinate children, just like I showed you with the meningococcal C model, and you protect other people, and that adds to the cost effectiveness. So if we want to prevent mortality and morbidity, we need a new approach. We need to interrupt transmission. We vaccinate children. We do need to get reasonably high coverage. We need to do it quickly rather than a slow build-up of the program. And here's what we've started to see. Vaccinating, and what we did is we vaccinated in pilot areas to compare with non-pilot areas. And if you look at the influenza-like illness rate in all age groups, we're only vaccinating children now, so if you look at the influenza-like illness rate in all ages, and in the non-pilot area, 65 per 100,000. In the pilot area, 17.7 per 100,000. So by vaccinating children in the pilot areas, we have really brought down influenza-like illness in all ages. So the children are protecting themselves and the adults. Influenza positivity rate, the virus positivity rate, is half in the pilot areas compared to the non-pilot. The proportion of people going to accident in the emergency department with respiratory conditions goes from 7% in the non-pilot, 5.5% in the pilot. And there is an impact on influenza with a reduction of 50 per 100,000 cumulative incidence. And if we look at, again, vaccinating in schools, here are the children aged 5 to 10, and there's a 94% reduction of influenza-like illness in the vaccinated children. So they benefit. 74% reduction in the vaccinated children in the emergency department. 93% reduction in hospital admission in the vaccinated children. But now look at the over 17 who are not vaccinated, and in the pilot area you've got a 60% reduction in the over 17s. So the children are protecting other people. So the policy is effective, and we've already modelled that it's going to be cost effective. You can use cost effectiveness to choose your strategy. This is HPV vaccination, and the question that we're asking here is the effect of age of vaccinating at 12, 13 or 14 years. And we're looking at whether the vaccine protects for 10 years, 20 years, or is lifelong. And here's our band of 20 to 30,000. And let's just take this one here. You've got 10 years protection, and you vaccinate girls at age 12, and the probability of it being cost effective is very low. If you had vaccinated them at 14, well, you're sort of just around 60% at the upper margin of it being cost effective. But at the lower margin, it's only 20% probable that this is cost effective. So, short duration of protection at age 10 is hopeless. Short duration of protection at age 14 is not very good either. But if you have lifelong immunity, it doesn't matter if you vaccinate at 12, 13 or 14. You've got an extremely high probability that this is cost effective, and this is assuming 80% vaccine coverage, and that is what we have achieved in the UK. I don't know if any of you know what the vaccine coverage for HPV is in France.
50%?
50?
10? No, 15.
15, I think it's about 30 actually,
Fine.
but that's pretty rubbish. And that is not a good use of resources. That money is effectively being wasted. So here we've looked at different vaccine strategies as to whether they'll be cost effective. But you can use the same thing for a different question. And the question here, we've said, is, well, what about vaccinating girls age 12, and we're going to look at 3 different coverages, 80, 70, 90% coverage against 3 different lengths of protection. So if the protection is only 10 years, it really doesn't matter what coverage you've got, it's not going to be cost effective. If your vaccine is lifelong and you get these different levels of coverage, 70, 80 or 90, it's highly likely to be cost effective. But by far the best, of course, is 90%. If you get 90% uptake with lifelong immunity, it's going to be cost effective. But if you get less than 70% uptake, which isn't shown here, it's not a good use of money. just vaccinating girls. It's actually better value to vaccinate girls and boys at low coverage. We now want to know about defining our program. We've shown that this is going to be a good use of money, but what about the implementation? So we've got a number of choices. We vaccinate just the girls. We do a catch-up for girls 12 to 14, 12 to 16, 12 to 18. We take the catch-up up to women of 25. We vaccinate boys. Here is our cost per collie. We know that that's really good. If you bring a catch-up in, it's getting better. Take the catch-up up to women at 18 years. It's now looking really good. Include women at up to 25, from 18 to 25, and the cost per collie goes right up. Why? Well, because so many of those women have already been exposed to HPV. So between 18 to 25, the probability of exposure to HPV becomes very, very high indeed. And so vaccinating the women after the age of 18 is not necessarily a good use of resources. It may be very politically attractive, but it's not a good use of money. What happens if you then want to vaccinate the girls at 12 and boys? If you get over 80% coverage, it is a really bad use of money. So here we've used value, cost effectiveness to define the implementation of our immunization program.
When you do this, you're just looking for cervical cancer.
We're just looking at
cervical cancer, just for uterine cervical cancer.
Yeah, this time was just based on cervical cancer. It was not looking at the time, there was not data on oropharyngeal and anal.
So it's probably completely wrong. It's a model.
Of course it's a model. Over the long-term run, it isn't wrong, because the benefit from preventing cervical cancer will be exactly the same as the benefit from preventing the other modalities of cancer.
Yeah, the boys get more oropharynx.
That raises a different issue about how you deal with MSM. Because vaccinating all, it's another argument, but it is simplistic, because it doesn't deal with MSM, which is much more complicated.
And not with oropharynx cancer.
But the same benefit that comes from preventing cervical cancer will come from the benefit. We are currently seeing increases in oropharyngeal cancer, but that is not the future. The future is that we will see decreases in oropharyngeal cancer through the vaccination of girls
because of transmission.
Because of transmission, because of high coverage, apart from in MSM.
Yeah, of course.
So I'm going to give you a quick example of when not to use cost effectiveness. This is pertussis. The left axis is the incidence per 100,000 in people 6 months of age over, and here it's in less than 6 months of age. The highest attack rate of all is in the children under 6 months of age, where the rate is 10 times the rate in people who are over 6 months of age. Up to this period, there were 4 deaths a year. At this time, there were 15 or 16 deaths from pertussis, all in children under 6 months of age. So a sudden, very big increase in pertussis in adolescents, and particularly in children under 6 months of age. Is it due to failure to vaccinate? Here's the coverage data for pertussis vaccine in children by their 2nd birthday. It's not due to failure to vaccinate. So the next question was, is this due to late vaccination? And so we went into an analysis of the different options. And one of them is, what about vaccinating adolescents? I showed you there's a high rate in adolescents. Vaccinate adolescents, and then we'll stop pertussis. Well, the purpose is to interrupt transmission, stop the adolescents infecting young children, take forever to have an impact. You could do it in the future, but it won't stop those deaths that I've shown you. So we then said, Is that increase because the children are not being vaccinated on time? There's delay, there's hesitancy, parents are not bringing their children to be vaccinated at the required age. So we looked then at the age of the cases of pertussis. And these are the ages of the cases of pertussis. This is where protection comes from their first dose, protection comes from their second dose, protection comes from their third dose. So the great majority of cases are early. So we went back into the UK, into computer systems in the UK that run the immunisation programme and said, what is the compliance around the recommended ages? How tight is the actual age of immunisation against the recommended age? Answer, extraordinarily tight. Because children come when the computer system invites them. The computer invites them to come next Wednesday at this clinic, at this time, so they come. So it's not delayed immunisation. So if we were to tell the doctors, hurry up and vaccinate on time, it wouldn't make any difference because they're already being vaccinated on time. The disease is occurring before they get vaccinated. So we then said, what if we bring the age of vaccination earlier? Instead of being 8 weeks for the first dose, bring it down to 6 weeks. It's complicated to do, but what if we did that? Bring it down to by 2 weeks, and you really would make no impact on the majority of cases of pertussis. So that's not going to help. So the last was, well, what if we vaccinate pregnant mothers? Vaccinate the mother in late pregnancy. The antibodies that she produces will cross the placenta to protect the baby, and we would then prevent all of these. So there I am on a Friday afternoon in August. Unlike France might close in August. Working, looking at all of this, thinking about what to do. And I get a phone call from the Office of the Secretary of State. He's also working in August. And people from his office saying, the Secretary of State would like some information on whooping cough as he's seen the recent report. I thought he had more important things to do. And my plan that Friday afternoon had been to phone his office to say, I need to come and talk to the Secretary of State about pertussis. But he had seen a routine report that said that whooping cough had gone up in young children and was causing deaths, and he wanted more information. So at 10 o'clock on Monday morning, I go off to see the Secretary of State. And I take him through all that evidence, and he says, yes, we must do that. We should ask the Joint Committee on Vaccination, which is the UK Advisory Committee. Let's ask the committee for their advice. And I said, don't do that. I said, well, why do we not ask our expert committee for advice? Don't do it. Because we have legislation that says the following. You should participate in an important public health program such as vaccination. That's good. Yeah. You have the right to receive the vaccinations that the committee recommends. So if Secretary of State goes to the committee and they recommend, you've got the right to receive it. When the committee makes a recommendation, the Secretary of State is obliged to implement it. Well, that's all okay, isn't it? That's all getting what we want. But in the small print, there's a problem. You go into the small print of the regulations. This obligation applies where the committee makes a recommendation. And here are some of the requirements, we can forget those, but it must be based on an assessment which demonstrates cost effectiveness. So if the Secretary of State asks the committee for advice, They give advice. He must implement it if they can show that it's cost effective. How long do you think it takes to make a model, like the ones I've already shown you, to show that it would be cost effective? Well, you get the epidemiologists and the modelers, and you say to them, do this. And they say, fine, we're going to need some more money, we're going to need some time, we're going to need some more computers, and we reckon this will take between 1 and 2 years. We're pretty sure that it will be cost effective to vaccinate pregnant women, but it's going to take up to 2 years to get the model. And that's why I said to the Secretary of State, don't ask. Because if you ask, you trigger this. You say this is a national level outbreak. You don't ask for cost effectiveness. So there are times when you do not use the economics and the values, and you go back to the old model. We've got too much disease, we need to stop it. So you choose your courses for the horses. What did we achieve? Within months, we had got up to over 70% uptake in pregnant women, which is better, I think, than anywhere in the world. We were able to show, and it has never been shown before, high vaccine efficacy from vaccinating pregnant women to stop pertussis in their young children. It had never been shown. Antibody transmission from mother to baby had been shown. Protective efficacy had never been shown. And we showed that if you vaccinate at the right time in pregnancy, you get high efficacy. As you vaccinate nearer and nearer to birth, the efficacy goes down because you haven't built up the maternal antibodies. And we were able to conclude that we put the program in place quickly. We got high coverage, we got high efficacy, we showed safety, and we were going to follow the infants to see what happened. And so that's where we did not use cost effectiveness and simply went on the disease burden. Now, I'm going to end on just a sort of philosophic approach. We've looked at very narrow health-related benefits, but should we be thinking more widely about the benefits of vaccination? Is it just preventing disease and preventing sequelae, or other ways of looking at the values? Now, this is a complicated series of interrelationships between immunization, financial and programmatic synergies, improved equity. The more children you vaccinate, the more you improve equity, because you progressively diminish the inequalities that exist in our societies. So you improve equity, you get health gains, and then you get healthcare cost savings, but you now start to see some other things. You get care-related productivity gains. People who are not ill are in work. Parents whose children are not ill are in work. And you start to get productivity gains related to other capabilities. You get the compounding of the health effect related to productivity. This now improves household security. It improves the public sector budget because your economy becomes more effective. And this money never comes back to health. So health improves the public sector, improves household behavior, improves macroeconomic impact, both long and short term, and none of these benefits come back into the health budget. So immunization, acting as a little bit up here, has done all of these things that are not acknowledged in our models. So just like we didn't take account of transmission, we're not taking account of these. And that was the perspective of one economist, modeler, and here's the perspective from a completely independent one. So currently, we take a narrow perspective, we look at healthcare cost saving, we look a little bit at care-related productivity. And that means the savings of expenditures, the saving of their productive time. But that's pretty narrow when we could be thinking again about all of these different elements of benefit that we are not currently allowing vaccination to include in our models. And these are all of the extended benefits that come from our vaccine program. So, what about going beyond health? There are improvements in cognitive ability in vaccinated children that lead to higher productivity. Vaccinated children achieve higher test scores compared with non-vaccinated children, which translates into, again, a return on investment from vaccines. Immunization is just like education in that it promotes economic well-being, and we don't take account of that in our model. And if education is the highest of our interventions in development, vaccination is coming very close. So, healthy children have better school attendance, they avoid the long-term sequelae from neurological complications, they become adults with higher productivity, they have a higher utilitarian value, and older family members, so I'm now talking about adult vaccination or children protecting adults. Older adults tend to be healthier in families where there are vaccinated children. They have lower rates of absenteeism, so higher productivity. And economists have failed to recognize the full economic benefits of health, and they undervalue many health interventions, including vaccination. Undervaluation translates into underinvestment, both in the delivery and development of vaccines, and this may be substantial. So I've taken you from these diseases are bad, so we should prevent them. It's a good use of resources in most circumstances to prevent disease. We can use the economic analysis to define our strategies for how and where and when we vaccinate. And we are, even with all of that, underestimating the wider value of our vaccination program. So, I leave you with a few thoughts. Should economic analysis be used to set vaccine policy? Should the same threshold be used for vaccines as non-vaccine pharmaceuticals? Yeah? If you answer yes to that, it means we have a level playing field of how you choose to spend your money. Do you spend it in treatment? Do you spend it in prevention? What is the right threshold for payment? Is it 50,000 euro per quad? Is it 100? Is it 150? How do we choose our threshold? Is it right to include the indirect costs, as I've been showing you in the last part, for vaccines, but not for other therapeutics? And to go back to the meningitis B parliamentary petition, should public demand overrule economic considerations? I don't know the answers, and I would be delighted if any of you did. But I leave those with you as thoughts based on what I've already shown you. Thank you, and it's been my pleasure.
Just the very last question. Probably, I think that public demand had economic consequences, but we don't know how to measure it. But there is consequences of this.
Public demand operates in both directions. I mean, public demand against a vaccine,
Of course.
and there are examples in France, hepatitis B, HPV, where the policy was rightly defined, but public demand made it not cost effective?
Well, I think in France it's a little bit different. No, for both HPV and HPV, the politics was terrible. So the vitamin issue of health is terrible in most states. But in this case, there is the only thing that I was saying about it. I don't know the cost of the public demand unsatisfied. I don't know the cost of that. It doesn't mean that there is it does not overrule economic consideration. I'm just talking about that. It is something we cannot measure now. We don't know, and specifically on long-term things. So in confidence or in,
I think that's true.
In one of fewer indirect costs, you get gain in fear. So if people
prevention,
the
prevention of fear.
Prevention. So if you get a picture like that, we don't do that. That means that for 1 year, all the mothers that you have a child like that are going to be in an emergency or more. And this is there is a cost that we don't know how to evaluate that.
I agree absolutely that just that fear element has a health consequence. That if the parents fear meningococcal disease, which we know they will do, we know that, we have evidence for that, they fear meningococcal disease, and therefore they have an exaggerated sense of possibility, and so the burden on the resources of your health program is considerable, that would not happen if they were confident that their children would not be getting meningococcal disease. Accepted.
And there is something. The vaccine that is working, I've been involved a long time ago, 24 years ago, in evaluating the cost-effectiveness of hemophilus B for my government. So it was very, very easy because it became theft, and the cost is just tremendous. So that's what's fine. What is really interesting, and this is why I'm still discussing on meningococcus, that the easiest thing that we have in France in all vaccine is vaccine against meningitis. Everybody wants it.
No problem.
And we get incredible coverage as soon as you say to the pediatrician and the mother to get something against even rare meningitis. Everybody wants it. It's very sensitive.
And that has been the case already with the meningitis B program in the UK. The coverage is already extraordinarily high. Within months of the program starting, every mother wanted their children to be vaccinated. Sure. And
it's very unique because it's the first time that I show that I've seen presentation for people claiming the vaccine. In this country, we get plenty of problem with people claiming that they don't want the vaccine.
And now
it's the first, it's the first example that I've seen.
750,000 just on Facebook signed a petition.
Because it is meningitis.
Yeah, of course.
So, in addition to having terrible politicians in France that govern only according to polls and petitions, and which are much less rational than British politicians, French people have a very strange perception of vaccines, and they by definition fear vaccines in the first instance. So what is the perception of the UK inhabitants of vaccines? For example, for flu vaccines. I've been responsible for hospital-acquired infection control for 5 years, and every year I try to implement the vaccination of health personnel, and we barely reach 20 to 25% coverage. So what is the perception of United Kingdom inhabitants?
Well, it's not that different in a way. The coverage for people 65 and over is 75%. The coverage for people below that age with risk factors, so people with heart disease, respiratory disease, renal disease, liver disease, neurological, and so on, is 50%. For pregnant women is 50%. For healthcare workers is around 50%. And when you ask them, do you recommend flu? You ask primary care doctors, do you recommend flu vaccine for your patients? Oh yes. Do you have flu vaccine? No. And you say, well, why not? And they say, oh, it can give you flu. And you say, no, it can't. And then they say, oh, well, I know someone that had really bad flu just after they had the vaccine. And then they say, I don't want one of the reactions. So you say, well, what reaction is it you don't want? I don't know, but I know someone that had a bad, you know, and they are illogical. They have the information, and they can't internalize the information. And when we saw year after year after year that we only get 50% coverage in people with risk factors, people who've got a 50 times higher chance of dying from flu, people with liver disease, people who are immunosuppressed. It's another lecture I could do another time. People with those conditions have a between 40 and 50 times higher risk of dying from flu than the average population, the healthy population. So they are at extraordinarily high risk. And we cannot get coverage up above 50% in those people. We tried and tried, we did publicity, we did advertising, we did direct intervention to raise the importance of flu for these people. Year after year, no change. And that's why we said the only effective intervention is to stop transmission, stop them getting flu by vaccinating children. And the flu vaccine program is already showing, we don't know the impact yet on the high risk, but we can see the impact on the community. And it's cost effective to do it. So it's a good use of resources.
Okay, thank you very much.